Ruth and I are delighted to be here this morning, and John is sorry he can't be here, but I know he's been at these seminars before and he's always really enjoyed them. So he has contributed to this presentation. You know, he's helped develop it as well. So, but Ruth thankfully has agreed to step in at short notice. So we're very grateful for that. I'm Patricia Gillen, and I work in a joint post. I'm a nurse and a midwife, and I work between the Southern Health and Social Care Trust as Head of Research and Development for Nurses, Midwives and Allied Health Professionals. And then I'm also aligned with Ulster University in the School of Nursing, and I'm a reader there. So I have a sort of quite a wide remit, and my role is really about trying to support practitioners in practice to do research and development activity and help them there. And then I have my normal sort of bit in the university, which is all about research and teaching and all the usual things that go on in university. Just to say that Paula McFadden, ordinarily, I'm sure many of you know Paula, would have been here to do this seminar along with John. Paula unfortunately is off at the minute on sick leave. So I'm trying to keep the project running along with, we have a great team of people, which we'll tell you a little bit more about when we start the presentation. And clearly we have Ruth that who's working on them. She's our research associate and doing a fab job and keeping everything moving along. So I'll hand over to Ruth, maybe just to introduce herself now.
So I'm Ruth, as Patricia said, I am a research assistant on the project. But my role is to work on the health and social care research and the study. My background's a bit of a mixed background. It's physical activity and mental health and business. So it's a bit of a widespread area, but I've been focusing on the health and social care sector now for the last couple of months and helping keep this project going while Paul's off on leave. So I'm just going to hand you back to Patricia.
Okay, so we'll make a start. I'll just share my screen, and we've had a wee practice, and of course it always works when you're practicing, but it doesn't always work when we start, but let's hope so. Okay, so everyone can see that, I take it okay. So thank you. So as Ruth has said, we're working on this project. It's called Health and Social Care Workers, Quality of Working Life and Coping while Working During the COVID-19 Pandemic. Particularly, we're looking at phase 3 of the study, which was from May to July of this year. And as you can see, there's a large team of us who've been involved in this study, and Paul has been leading us up. We're from a range of institutions: Ulster University, Queen's University, King's College London, Bath Spa University. So, and a mix of people from social work background, nursing midwifery background, and also other like human resources background, and clearly Ruth's bringing her expertise in research as well. So the methods, so the overall aim, I suppose, in relation to this study is, as I've said, to examine really the impact of providing health and social care in the UK during COVID-19. And we were looking specifically at nurses, midwives, allied health professionals, social care workers and social workers. And we've tried to focus in on the social work aspect of the study for this presentation. But there's some general data there as well. So our phase 1 started in May to July of last year. And that started off with an online survey. Then in November to January of this year, we had the survey and focus groups. And then just past in May and July there, we've had another online survey and focus groups. So within the survey itself, the main things that we measured were clearly background demographics. It was important for us to understand who the people were who were responding, their ages, their roles, all of those various aspects that you'd expect. And then we used some other validated measures to measure some key aspects of wellbeing and coping. These included mental wellbeing, the Short Warwick Edinburgh Mental Wellbeing Scale, the Quality of Working Life Scale, burnout using the Copenhagen Burnout Inventory, and we used that in phases 2 and 3. That was something that sort of emerged in phase 1, and we thought it was important therefore to develop further in the next phases. Coping, Brief Cope, and the Clark et al.'s Coping with Work and Family Stressors Scale. And then we had a couple of qualitative open-ended questions as well. So in relation to the participants' demographics, as you can see in phase 3, our latest phase, we had 2,721 respondents, and they were predominantly female, and which we would expect from a workforce, I suppose, that is predominantly female in health and social care. Nearly 90% of our respondents were of white ethnicity. We had 83.7% who were aged 30 to 59. And you can see that we had just over 40% who worked in the community, with 60% working with adults or older people, and 33% had 11 to 20 years of experience working in health and social care. So in relation to the number of responses per country, you can see out of that 2,721, predominantly our respondents came from Northern Ireland, then from Scotland, England, and then Wales. In relation to Northern Ireland in particular, and social work and social care in particular, most of our respondents on each of the phases actually have been from social work and social care. And as you can see here, we had a large overall response rate of 853 from social care and 753 from social work. And you can see that from Northern Ireland particularly, we had 368 social care workers and 315 social workers. So this gives you an idea of the responses per occupational group, and that just allows you to draw a little bit of comparison about the numbers who actually responded to the survey from Northern Ireland. And you can see that we had really a good, strong response rate from Northern Ireland. Midwifery, we've always found it quite challenging to get respondents, and they are a smaller professional group. Like in Northern Ireland, for example, there's something like 1,400 midwives, but we are still working on that one. But we've always, as I've said, had good, strong response rates from social work and social care. So one of the key things, as I said, we were wanting to look at more closely in this study was the ways of coping. And this slide gives you an overview of the ways of coping across the UK. And you can see the different phases are shown here because it's important as we move along to actually show what the differences are across the phases of the study. And you can see on the left-hand side of the slide, we had predominantly more positive ways of coping being used in the earlier part of the pandemic, or when we measured our data in the earlier phases. And you can see that as we've moved towards the third phase, you can see that those more positive means have been falling, and the more negative ways of coping, or less positive ways of coping, have been increasing. And those have included things like substance use, behavioural disengagement, and self-blame. And we show a little bit more of a breakdown in these as we go along. You can see here specifically in relation to Northern Ireland, that curve, that graph really reflects that larger curve. And we are still moving our staff here in Northern Ireland within nursing, midwifery, AHPs and social work and social care are moving towards those more negative coping mechanisms as the phases of the pandemic have progressed. So in relation to that work-life interface, what were people telling us about that, what they were having to cope with and how they were coping, and what their experiences were. And we can see that people very much, that work-life interface has never been more important for people. I think that's something that the pandemic has really drawn to our attention. And you can see here that some people felt that, there was an increase in morale at work because of remote working. So many people were encouraged to work at home if they could. And I know that for many social workers that was possible, not for all. And some people felt that caused an increase in morale, which was good, and that people still did work well together. And that for some people, it did help them to maintain that work-life balance in a better way. They didn't have to commute. They didn't have that added time built into their working day, and that they found that working from home was a positive experience for them. Some people, however, reflected how difficult it was to switch off, even if they were coming home, because they were under such pressure at work. And they also had that added pressure of concern about COVID-19 in relation to both their staff and their service users' well-being. And also, you know, people, I think, had that added concern that they were afraid that they would do something wrong and they would be blamed by the trust or the regulator. And that came from a care home manager in Northern Ireland. And in relation to people feeling that it isn't always possible to do what you always did in the same way, because they perhaps were working at home or having to meet with clients, perhaps even just via telephone or on video, by video. It meant that this really relational task, I think very much that relationship that people have with their patients, with their clients, was very important. And some people felt that they just really couldn't maintain the same relationship, and they found it really hard to maintain their targets, to meet their targets and keep the standards maintained. So in relation to the factors associated with coping then specifically, we can see, and we analysed this clearly, Ruth and John did quite a bit of this analysis, really to look more closely at what aspects of coping were important, particularly in relation to social workers. So use of emotional or instrumental supports were above average among social workers, but below average among social care workers. Social workers were also the group most likely to cope by venting. So having a bit of a rant and a rave, as we would say, and had above average levels of substance use. And as you see, if you think back to that slide, you can see how that had changed over time. Line managers were more likely than others to use acceptance, active coping, positive reframing and planning, so those more positive aspects, and were less likely to use venting. And also, however, line managers had the highest levels of behavioural disengagement and self-blame. So they had some of the less positive means of coping as well. Coping through acceptance was higher among respondents in non-hospital settings, so those people who were in community or care home settings coped more through acceptance than others. And positive and constructive coping was lower in some areas of practice. So it was identified that those working in mental health settings reported less planning and active coping, while staff working in learning disability were less likely to have sought instrumental support, particularly compared with counterparts in physical disability settings who had above average scores for this coping method. And then in relation to age and ethnicity and gender of respondents, they were also strong predictors of coping styles. For example, with younger respondents, they were more likely to engage in self-blame. And from a ethnicity point of view, Black respondents had higher scores for positive reframing. So I'll just hand over to Ruth now.
Okay, so the next part of our study, as Patricia said earlier, we looked at burnout based on phase 1. So a lot of staff obviously had highlighted that the pandemic had started increasing their level of burnout in the workplace. We only measured that obviously in phase 2 and 3, and we're going to continue to measure it in our next 2 surveys as well in phase 4 and 5. So the slide here just shows an overview of the UK-wide mean burnout scores for personal burnout, work-related burnout and client-related burnout, and then you can see comparisons aside from Northern Ireland burnout. So if we look at the personal burnout, work-related burnout and client burnout in the UK, between phases 2 and 3, there was an increase suggesting that as the pandemic continued, working conditions changed, connections changed, communication, that all changed in the workplace. And particularly with the changes in restrictions and vaccinations, that all increased burnout among staff, particularly in the health and social care sector. And this increase was significantly different, so it got worse. But when we looked at Northern Ireland individually between those 2 phases, burnout actually improved slightly. There was a decrease, so people didn't feel as burnt out between phase 2, which was November last year, to May and July this year. Again, that could just be the different population that we've looked at, but within this section, it shows that maybe the change in workplace arrangements of working from home may have had a benefit to those participants, and therefore they suffered burnout less. Over 70% of those that we surveyed had moderate to severe burnout levels. So it meant that their burnout was quite high, and they felt stressed a lot in relation to their personal burnout and their work-related burnout. But when we looked at client burnout, it was very low. So therefore, people in the health and social care work there didn't feel as burnt out dealing with their clients as they did with their personal and their work circumstances. And when we broke this down further, we looked at older age groups tended to have a lower level of burnout, and whereas similar to coping, the younger people tended to struggle. So those under the age of 40 had high levels of burnout. Similar, females had higher personal and client-related burnout than male counterparts in the health and social care sector. And those that were overwhelmed, their burnout was also higher, which we'll look at a bit in a minute. And then any of those wanting to leave their profession, burnout was highly correlated to that. So the higher the level of burnout, the more respondents in the health and social care sector felt that they wanted to leave their roles or their occupations and maybe try a different profession. And the two reasons behind that were that they found their jobs were just too stressful now, and that it began impacting on their mental health and their well-being and even their personal life. It also kind of started merging into one as that burnout started increasing. So part of the reason for the burnout was that change in connection and that change in conditions, which is something that we find has been consistent across all three of our phases so far. That missing face-to-face interactions proved to be huge, particularly in social care and social work. And particularly across the UK, social workers and social care workers, there's been issues in turnover rates, so they've had a lot of staff leaving, and that's due to the changing conditions in the workplace and caseloads increasing. So social workers said that they found that harder to maintain their level of work because, yes, that we were in a pandemic, but cases were still increasing. And as the pandemic changes over time, those cases will continue to increase because of how the pandemic has changed circumstances for a lot of people. And that isn't being maybe looked at as much as they would like. So therefore their workloads increased, which means that they're burning out quicker, which means people are going to be off work possibly, or they're going to want to leave their profession. Some staff did think about allowing that control at home, so that flexibility, those changing conditions, and being able to self-manage their plan. That actually they found was a positive. But some people find that the constant changing circumstances were difficult for the clients that they were dealing with, which in turn created difficulties for them. So that connection wasn't the same, particularly with the less face-to-face contacts. And then they talked about the difference between management and the employers in the workplace. They obviously found that there was differences in that, and there was miscommunication at times, which caused increased burnout because they weren't sure of who to contact in times of real need, which all links into their mental well-being. So what we found across the UK was that mental well-being between phases 1 and phase 3 decreased significantly. So there's a huge drop from when we first measured them in May in 2020 to when we measured again in May 2021. In between that, well-being has slightly improved from when we looked at November this time last year to May just there recently. But as you can see, there is still a lot of countries are decreasing, and the differences between 2 and 3 aren't significant. There's no big difference. And again, it could just be the difference in sample sizes between those two groups. But across the UK, we can clearly see that well-being is still suffering as the pandemic continues or as we move out of different restrictions. The health and social care workforce are definitely struggling. So when we looked at breaking this down even further, social care and social workers were one of the groups that well-being continued to decline. So even though UK-wise, across all the countries, there was that slight increase, that never occurred between the social work and social work population. That continued to decline. So they had went down, I think, two marks across the UK, which was a lot different. Also, those that worked from home all the time during the pandemic, rather than being in and out of the office or in the office all the time, they found that those that work at home had higher well-being. because they had a better life-work balance possibly. Which some of them saying they actually found that they were able to manage their workload a lot better because they weren't constantly having to go to different places. But on the other half, those that worked from home also found that it affected their well-being slightly because they were dealing with clients in a different manner. So we can see this is across Northern Ireland. So I broke it down by the different occupations. So you can see there that social care workers in Northern Ireland were slightly different than the UK average. Social care workers continued to decline, and that's quite a big decline from 21 to 20.53. Again, there's that slight increase in social work, but the general trend across the three phases is that there's a decline in that profession, which is the same in midwifery, but it's still a lot higher. These values that we found for wellbeing were a lot lower than the rest of the UK general population, which they report a figure of 23.61. So we're nearly a lot of the time by phase 3, we've come down by three different marks, which shows that across the UK, the health and social care workforce have had a significant impact on their wellbeing. And that could be because they're more burnt out and that their work-related quality of life has changed. So now when we look at quality of working life across the UK, it decreased in Northern Ireland over all 3 time points. And when we're looking at UK-wide, there was that slight increase between 2 and 3, but a significant increase between 1 and 3. But across Northern Ireland, the scores went from 76 right down to 73, which shows that even with the changes in our working conditions, it didn't seem to get better with the new guidelines and support from employers. People seem to struggle more as the pandemic continued in their work related. So they had change in working conditions was a factor, stress at work was a factor, the control of their work, so being able to control their work, all those different elements. We examined at different levels and found that particularly across Northern Ireland, they significantly decreased over time, particularly in the social care and social work background. So as you can see here, social workers really declined their quality of life in Northern Ireland, their work-related quality of life. So that was down to a lot more increase in caseloads and a lot more uncertainty, and a lot of backlash, particularly in the sector from clients that they were working with, and that lack of face-to-face interaction. Their jobs changed from what they were used to, and therefore it affected their quality of working life. And there was no difference in work-related quality of life that those respondents that were working from home and those that were in offices or working from home some of the time. But we did find that social care and social work declined lower across the UK in social care and social work compared to nursing and AHPs. Midwifery actually had the lowest at the end across the whole UK. And a lot of this came down to communication, because communication at home wasn't the same as it was in the office for a lot of people. So people in the social work and social care background actually felt that it needed to be communicated, that they were appreciated and valued. They thought at times that working from home they were forgot about, which didn't really help. And then even those that were going out and dealing with clients and those service users, they found that there was a miscommunication regarding public health and how they were meant to actually continue doing their jobs. And these trends were sort of similar across all 3 phases, but it was more now that people felt there was less respect and less value on the jobs that they were actually doing. And the fact that management was so busy now, and because of all the increasing issues across these services, that it meant then they had less time to actually talk to their managers about the issues that were going on. So for that communication, there seemed to be a lack of 2-way communication, which therefore resulted in issues between work-related quality of life. And that then in turn creates issues in wellbeing and burnout across the workforce, particularly in the social care and the social work sector. So as we can see here, the effects of the pandemic was something that we measured. We looked at how the pandemic affected all the different occupations and across all the different countries. So across Northern Ireland, a lot of workers felt that they were impacted by the pandemic, but it wasn't a significant impact. So they were still able to do their jobs. And yes, their roles had changed slightly, but they were still able to actually work. And when we looked at the increase in impact on the overwhelming impact of the pandemic, respondents' well-being and quality of working life decreased. So therefore, they suffered more in those areas, and their mental and physical health began to suffer as well. but burnout increased across, particularly in personal and work-related burnout. Client-related burnout also then increased. Again, it's still a lot lower than the other two, but it just showed that as time moved on, our service users were therefore becoming they had more issues, and therefore it was increasing the burnout in the staff, because there was issues that obviously staff can't deal with. Again, if we look across the different occupations in the UK and across in Northern Ireland, you can see that each profession is affected slightly differently. So we find a lot of the time that the social workers found that they were overwhelmed by increasing pressure, and there wasn't much difference between the UK-wide social work and the Northern Ireland-wide social work. It wasn't a significant difference. But across, social work tended to have a bigger impact. So whether it's impacted just slightly or overwhelming impact, social work and social care workers in Northern Ireland definitely felt it more during the pandemic. We also looked at loads of different demographics and those different statistics, but we thought that the comparison of sick days across the population was an interesting one to examine. So Northern Ireland actually had staff taking less sick days. Staff worked more hours during the pandemic and didn't take a lot of sick leave. As you can see, over 54.9% of those in Northern Ireland didn't have a day off. And this was over the course of the pandemic that we measured during phase 3. And then in UK-wide, it was 48%. So there is a difference between the UK-wide stats and the Northern Ireland-wide stats. The Northern Ireland workers didn't tend to have the same amount of days off, which therefore could have influenced their level of burnout. Again, we looked at COVID-related absences, and there wasn't much of a difference between Northern Ireland and the UK-related statistics on this. UK had slightly more related absences due to COVID, but 50% of the workforce didn't have any COVID-related absences. So that leads us on to all our statistics and our qualitative data from the focus groups and survey helped lead to 15 good practice recommendations, which were then categorized into individual, organizational, and policy level recommendations. So they can be found in our wider report, so they're more detailed, but we've broken them down just briefly here. Oh, I'm not sure why that moved, sorry. So when we look at policy, people were concerned by the efforts required, or concerted by the efforts. So government needed to make more of an effort, and so did employers, to make working in the health and social care sectors an attractive option. As I highlighted earlier, there was a great intent to leave, and that was due to increased burnout. So therefore, looking at recommendations, it's recommended that they need to try and make working in this sector a more attractive option, and that there's other factors obviously that come into play within that. But trying to encourage people to stay in the health and social care sector, or to join the health and social care sector as work is important, particularly due to the high turnover rate that we're experiencing across the UK. From an organisational point of view, a lot of people highlighted that managerial support was very important, and this is where effective communication came in. A lot of respondents that weren't line managers felt that they wanted to see their managers more from time to time and know that they felt valued and that their work pressures were being understood. So that's just that increased communication within an organisation has been something across the pandemic that a lot of people want to see, and particularly those working in the health and social care sector. On an individual level, that work-life interface, that has been something that's becoming really important, and that flexibility of working from home when you can. Obviously not all jobs allow that, but being able to have more flexible working hours and being able to work in more flexible ways, particularly with the use of online technology, has been highlighted as being beneficial to a lot of staff, because that increased flexibility helps their home work-life balance. And that's more an individual level. And that in turn should hopefully hope when they get that right balance, that should improve their well-being and their work-related quality of life and reduce their burnout. So obviously we just like to thank everybody. We were funded by different people, and this will be on the slides at the end, which will be distributed. We have a study website there, and you'll find all our current reports. We have a poster on this presentation, which just get a poster of our overall phase 3 results, which will show just each individual sort of sector between coping and Wellbeing, and has all that highlighted in graphics and just makes it clear and shorter. We also have our executive summary on our website and all of our phase reports, so from 1 to 3. And we have a Twitter account as well, which we'll be releasing more information on in the next few days. I'm just going to pass it back to Patricia.
Okay, thank you. That's the end of our presentation. So we're happy to take any questions that you might have or hear any comments or anything that you feel you want to share with us. So thanks very much.
That was very interesting. Thank you very much, ladies. Does anyone have any questions? No?
Alison, if nobody else is going to ask, I'm going to ask a question. Tricia and Ruth, a really great presentation. I had obviously the privilege of reading the report with great interest in relation to our social work and social care registrants. I suppose from our perspective, I'm very mindful of those 3 categories of recommendations. And I suppose I'm going to ask the really simple question from our perspective as the regulator. We've been doing a lot of work to try and promote the workforce, particularly within social work and social care. But look, is there more, particularly from yourselves as educational leads, that we could be doing as a regulator to really invest time, perhaps invest more engagement in helping particularly social workers and social care workers out there really to help them understand that this is a really good place to work in?
Yeah, I think it's quite interesting because I think and you'd be very aware of this, that as we've gone through, and anybody working in health and social care, we've sort of gone from being the heroes to being the devils. It's huge, and it keeps the feeling out there. It keeps changing, and as everything moves and changes, how people feel and how they respond. And I think there's also that sense of weariness that people are having now because this has gone on so long. And I think we all thought it would have been packed up and away a year ago, so it's all of that. So I think there is a great sense of people feeling valued and feeling appreciated. And I think that, employers can do a lot in that regard, making sure they're visible, making sure they're present. And I think from a regulator's point of view, there's also that thing about, as you've said, about it is a very valuable and honourable job to do. It does make a huge difference to people's lives, and there's not someone who could say that they haven't been touched in some way by a social worker or social care worker and their lives have been improved. So I think it's a very hard one because I think what is being talked about a lot, and not so much I haven't heard it, but it may be just I haven't heard it. I know within nursing and midwifery, there's a lot about pay, there's a lot about conditions, there's a lot about getting more staff, and it's how do you get more people to come on board whenever people are thinking, well, I'm not going to go and work there because I don't want to be working and so pressured and working so hard. And it's like a catch-22, but we need more people. We need more people to feel inspired, that actually doing a job where you're helping others is a brilliant job to do, because actually you do get, and there's lots of research to back this up, when you help others, you actually get a good feeling. When you make someone feel better, you generally, receive twice that back to yourself because, so I think a lot of it is about trying to increase the value that we place generally within our society on these roles. I think domiciliary care has always been the poor relation, and I don't mean that in any disrespectful way whatsoever. It's been, better than I, the one that has been totally challenged for funding, for staffing, for so many reasons. And yet that is one aspect that touches so many people's lives, and can make such a huge difference to people's quality of life. So I think there's something about us educating, not only, I just think the general public around, the brilliant work that is done in this sector across health and social care. and that, you know, if we can attract the right people in, you can have a great career, people can progress, there is somewhere to go. You don't need to stay where you are, you can progress, there are opportunities. So I think, you know, and I think NISC within Northern Ireland, you know, I think it's brilliant to have a Northern Ireland regulator for social work. I'd love to have it for nursing and midwifery. We don't have it. So I think you're in a great position as a regulator, because you can influence locally, and you clearly do influence locally, you know, and you can challenge at a local level, particularly with us being a devolved administration. You know, I think it's really important that the regulators are able to influence at that local level. So not quite sure, Declan, if that's actually answered your question, but yeah, I hope it has a little. Yeah,
it certainly has, Patricia. I mean, I can't focus any more than that whole point that you make. You know, it's probably not just down to our employers and the Social Care Council. We have a mindset change to make within our society, really, to see the value of social work and social care in relation to that whole profile raising, and obviously encouraging more into these two professions. So thank you.
Tricia, Sarah's just asking, given the ongoing situation, about future plans, and the next phase is being launched tomorrow, isn't it?
That's right. That's right. I don't know, Ruth, do you want to come in about that? Because Ruth's driving a lot of that on Twitter and social media and stuff. So yeah, good opportunity.
Yeah, so we're moving on to phase 4 of our research, which we will be doing a lot of comparisons across the other phases. So there's a lot of similarities in the questions. We've added some questions in more around work-life balance this time as well. That was in phase 3, so we're continuing to look at that, because that's obviously where the information is coming from at the minute, that importance between the work-life responsibilities and the changing in services, particularly as the pandemic continues. So we launched that survey tomorrow morning. So if you follow us on Twitter or our website, that information will come up there tomorrow morning with the survey link. We're also going to be having 3 focus groups in January and February, just in conjunction with our survey. So we obviously get more information from the actual people that are doing these jobs. So we're looking at managers, anybody in the front lines, so our social care workers, social workers, AHPs, nurses, midwives. We get all those opinions, and that'll help us then form recommendations and issue back. And then we're also looking this time at HR regulators. So then that means we can compare across what each different body is thinking, and try and create some kind of response to that. Because obviously each sector probably feels different as the pandemic has continued. Particularly those in management and HR might feel differently to those actually working with the service users. So it's to get those different opinions together and then try and make some sense of that. So we'll be launching those in January and February. So if you're interested, you can send us an email about that. And then again, our survey is out tomorrow. So we're hoping to increase our responses this time, and hopefully get a lot more respondents to try and get more information that we can actually do more of a comparison with.
That's great, Ruth. Hi, Sheena. I think Sheena had her hand up a wee minute ago.
Yeah, I was just going to put comments in the chat, but I suppose I mean, that was so interesting. And sorry, I was late coming into the presentation, but that whole link with trauma sensitive practice as well, where staff and the workforce feel held in mind by their managers, just like children need to be held in mind by their parents or by caring adults, and that kind of builds or supports resilience. And also the whole Michael West stuff about, you know, feeling valued, having some control and autonomy. And that, I think it was really interesting, some of the workers who said, I felt more trusted, I felt my managers appreciated what I was doing. And at the same time, there were others saying, I felt, you know, so stressed, undervalued. People didn't realize what I was doing and how this was stressing me or the workload. So I think it's, I mean, it really, obviously I'm part of the trying to roll out, you know, trauma sensitive practice and the development of that through the Safeguarding Board. But it really makes that argument, you know, we know a lot of this already, and it's just kind of reinforcing some of it. But it's very interesting to see that in really concrete views. So thank you very much.
Thank you. And I think that has come out that has come out quite a lot. It's the value of individual managers. You know, there are some people who are saying my manager has been brilliant. They couldn't have done more. They couldn't have helped us more. They couldn't have supported us more. They were always there. They were, you know, we knew we could contact them if we needed them. And yes, that bit about being trusted to get on with their work as well, that was a big deal for some people. But some people who weren't used to that find that very unnerving and difficult to deal with. So, you know, it's really hard. And I think it does come down to managers knowing their staff and knowing the individuals and taking account of individuals' needs. You know, and it's this thing about treating everybody equally is not treating everybody the same. You know, everybody's different, and we're asking a lot of managers. And I think also what came out was that people were recognizing that managers were also stressed. Managers were also under pressure, and that it's not just about the folk, you know, at different, you know, every level is getting the pressure, and it's about recognizing that. And you know, I must say we presented this at a few different places at senior management teams, and you could see that they were grateful for that acknowledgement, that the staff recognized they were under pressure too. You know, and it's almost like, oh, but sure, you know that, you would know that we know, but you know, they need to be told as well. So it's that sense of, you know, people being told they're appreciated, and you know, not just assuming that you know, that, you know, that people say, listen, that was a good job, you did really well, or, you know, gosh, you've been doing an amazing amount of work. You know, it is about actually putting words, and it can be just a very quick phone call, very quick conversation. It doesn't have to take a lot of time, you know. So thanks.
That's great. Any other questions? No? Okay.
Can I just ask a question just generally? If what we've been relying on, as Ruth has said, is very much going out via social media, and within Northern Ireland we have trust governance, so we can go out via the trusts, so we can get our collaborators in the trust to send information out about the study. But has anybody any other suggestions about how we can get, you know, the word out about the study, you know, where else we can use? And I know that people are busy and people may not want to do it, and that's absolutely fine. But how do we get the word out to those people who might want to be involved but maybe haven't heard about it? Or, you know, how do we do that better? You know, there may not be another answer. It's just one of those things. We keep trying to find another way to reach out further.
It's, we try to promote it at everything we're at, and we have it on our website as well, you know. Yeah. And we'll promote it as well.
And we rely very heavily on that, very much those connections, like with yourselves, and even we link in with Lisa Trigg in Wales and Social Care Scotland, and you know, very much rely on those organisations to use their networks to help us. So it's vital really to reaching out. But it's just in case there's something obvious that we're missing, which there could be. You never know. Yeah.
Well, we will do our best to keep promoting it so well, and I'm sure a lot of people on today will get it through our mailings as well. So it's really just about saying, you know, please do share it, and the more feedback and the input we get, the better for everybody. And
we are trying our very best to get the information out there. Because we have the website for the study, it means the reports are there, they're accessible to everybody, you know, the information is there. And we are trying to, you know, we're very grateful to NISC for giving us these opportunities to get a chance to talk to whoever we can, who can come along. And we're going out into the trusts, and we're putting it out into papers and trying our very best to get it out there. I know that one of the last times I did a presentation, that coping graph that showed, you know, the moving from the more positive to the negative aspects of coping, that struck a chord with one of the chief executives. And he was saying, okay, what can we do for our staff? Clearly staff are not, you know, they're using more negative means, and we know that. So what is it that we can do? So we've been starting to have meetings with occupational health, and, you know, and they're saying, well, yes, let's use this evidence to support what we're doing. And we're not saying that there isn't a lot of good work going on, but one of the challenges has been getting staff to engage with it. because they're already so busy and so stressed. They're like, oh God, I haven't time to take the support that's been offered because I'm just too busy. And so they're trying to work with all of that as well. So I would say that in the background, there's a lot of those discussions going on about, well, look, actually, what can we do? So if you do have any examples that you think you can feed into whoever your employers are about what they could be doing differently, I do genuinely think they would be grateful to hear it, because they're trying to respond, and they're not always sure they're getting it right, but they are trying their very best.
Yeah, there's a couple of suggestions there just on the chat, just training teams and at the Echo, and we do share it at our social care Echo, but more recently we've been attending other Echoes, like the care home activity Echoes, etc. So we will start to share that when we're out as well. So that was very good. Thank you.
That's great.
Well, that was very good. Might be a little bit shorter than planned, but lots of information there that was really interesting. So thank you very much. If nobody has any other questions, we will put it on the website. The recording will just need a little bit of editing, so it will take us a few days to do that, and we'll put the PowerPoint on. So it'll be there for everyone to see and share. Thank you very much, everybody, for coming, and thank you, Patricia and Ruth, for taking the time to join us this morning. Thank you.
Thank you very much, everyone. All the best.
Yeah.
Bye-bye. Bye-bye.